This is part 2 of a 3-part series in which we are attempting to explain why we think disc dislocations in the TMJ occur and how to try to prevent it. To review, there are terms which require a definition. The vertical holding fulcrum is defined as the most anterior occlusal contact between posterior teeth. It is usually the lower first premolar cusp tip in the mesial fossa of the upper first premolar. The function of the VHF is to maintain the vertical dimension during occlusal correction procedures. It is utilized the same way whether one's dealing with an orthotic or an equilibration. Again, for review, these are the terms that we use for movement of the condyle within the fossa. The detrusion-surtrusion terminology is stolen from Dr. Harvey Stollard, who was the father of gnathological terminology. Utilizing this concept is essential during the removal of the interferences to surtrusion, because the VHF acts as the pivot point around which the plane of occlusion rotates as the condyle rises toward the eminence. Whenever we alter occlusion, the position of the mandible relative to the maxilla changes. The vertical dimension and the plane of occlusion are most likely altered. How these occlusal surface corrections are handled can have a very large effect on both the condyle disposition within the fossa and the amount of tooth structure lost in the process. Understanding the rotational function of the VHF allows us to achieve the desired result with a minimum loss of tooth structure. An understanding of how this VHF rotation occurs while breaking down and reprogramming the existing engrams also allows us to achieve ideal positioning of the disc and condyle within the fossa. The utilization of the VHF is the vital concept that is necessary to achieve both goals. Dr. Bob Wilson figured this out using his ability to visualize mandibular movement in 3 dimensions. This diagrammatically illustrates the Fulcrum Principle. As the occlusal interferences to surtrusion are eliminated, the condyle is rising upward and forward around the fulcrum as it rises toward the eminence. When we state that the condyle rises upward and forward during surtrusion, it is helpful to visualize the rotational components of this movement. There are 2 fulcrums around which this rotation is occurring. First is the VHF, as depicted by the red line. Second is the origin of the most inferior fibers of the inferior head of the lateral pterygoid. We make that statement based on the assumption that those are the fibers which have the greatest stretching potential during the rise of the condyle. It is the stretch receptors which limit the elongation of any muscle past its resting length. Note the direction of force provided by the closing musculature to seat the condyle disc assemblies against the eminence. If we may digress for a moment, there is another facet in this discussion about how the stretch receptors limit the lengthening of a muscle past its maximum resting length. Conventional wisdom holds that the hinge opening of the human jaw is limited to X number of millimeters because beyond that point the airway is impinged upon. We would suggest that there is another equally compelling reason. Hinge opening stretches the fibers of both heads of the lateral pterygoid musculature. The stretch receptors demand protrusion when their physiological limit is reached. Now let's get back to the concept of the VHF. We are assuming that there is a contact in maximum intercuspation between the most anterior posterior teeth. This is, by definition, the VHF. Be sure that you just heard what we said. This is the contact in maximum intercuspation position, and we are assuming that the vertical dimension for this particular patient is about where it needs to remain. If one intends to change the vertical dimension, then it is an entirely different ballgame. This entire discussion assumes that we are accepting the patient's vertical dimension as adequate or correct. My brother was very skilled in mathematics, and when I asked him to help me figure out the mathematics of equilibration, he said, "Sure, we'll do some jawbone geometry." When we equilibrate a dentition or an orthotic, there is usually two things involved in the movement of the mandible from maximum intercuspation position to the centric relation position. There is almost always some retrusion and very frequently some surtrusion required to achieve centric relation. To understand the effect that each of these movements have on the occlusion, we will separate them out into their individual entities of jawbone geometry for clarity's sake. Remember this patient from part 1. This particular joint for her in MI has some protrusion and some detrusion. So to achieve centric relation for this particular joint, the condyle has to retrude back to centric relation and surtrude up to centric relation. Here is the jawbone geometry mathematical formula, which tells us how much tooth structure must be adjusted from the second molar, first molar, and second premolar for retrusion to occur given the VHF as a flat holding fulcrum. So here we are using the VHF to keep the vertical dimension the same at the VHF, in other words, the front end of the mandible, during the retrusion process as the condyle moves up and back on the eminence. Again, the formula tells us how many microns of tooth structure must be removed from the second molar, first molar, and the second premolar during the retrusion process. For this illustration, we are assuming that the retrusion at the flat VHF will be 1.5 millimeters and that the angle of the eminence is 30 degrees. Each lower cusp tip will now rise and go back up into the equalizer interference of its opposer. To achieve full retrusion to centric relation, we will have to remove 290 microns from the second molar, 181 from the first molar, and 77 microns from the second premolar. This permits the retrusive rise to centric relation. The critical jawbone geometry that one needs to understand here is that if the fossa contacts are not deepened by that amount, the condyle is actually forced into detrusion. In other words, the space between the condyle and the eminence is actually increased. The catch-22 in the previous statement about deepening each fossa for the rise of the condyle assumes that the plane of occlusion is flat. That is not necessarily the case. If the curve of Spee, as depicted by this red arc, happens to project exactly to the angle of the eminence, then those fossae would not need to be deepened at all. They would merely be extended in the plane of the curve of Spee. The geometry of retrusion at the tooth level is actually quite complex. That is one of the reasons why a precise equilibration is so difficult to do. Using the VHF to maintain vertical during this retrusive equilibration process will separate the anterior teeth. Because the flat VHF is the rotational fulcrum around which the mandible rotates as the condyle rises in retrusion. Now let's move on to a second scenario. If one chooses to recouple the front teeth by removing more tooth structure, then the geometry changes dramatically. This is because the plane of occlusion is now rising both in front and in back. With this geometry model, the retrusion amount remains the same at 1.5 millimeters. The angle of the eminence remains the same at 30 degrees, but we now have a cuspid ascent at 20 degrees. So now the amount of reduction of tooth structure at the second molar has to be 670 microns, at the first molar 633, at the second premolar 598, and at the first premolar 572 microns. Recoupling the anterior teeth has a huge price. Here we see a histogram display of the amount of tooth structure that must be removed to achieve a 1.5 millimeters of retrusion, depending upon whether a VHF is used or whether the front teeth are recoupled. One of our great teachers advocates the more conservative option of using an anterior orthotic to compensate for opening the anterior space and to recouple the anterior teeth and thus achieve disclusion at night in the event that they brux while they're asleep. Here we see an animation clip where the lower cusp tip rises into its opposing fossa while the condyle and disc retrude as a unit. Please note that the disc and condyle relationship is static. They retreat together as a unit. I'll run that again because it goes by pretty fast. The other component of jawbone geometry when achieving centric relation is when one needs to accomplish surtrusion. For the mathematics of this illustration, we will assume that the surtrusion will be 1.5 millimeters, and again the angle of the eminence is 30 degrees. When this occurs, the second molar rises 496 microns and moves protrusively 286 microns. This is what a lower cusp tip must do within its opposing fossa during the surtrusive movement. We'll now run a motion graphic of pure surtrusion. Be sure you notice that the disc is moving retrusively relative to the condyle to reestablish its central fovea posture with the condyle. That is the critical geometry of surtrusion. The vast majority of the time, both of these movements are occurring simultaneously. The composite movement of the condyle and disc and a cusp versus its opposing fossa is entirely dependent upon the angle and the amount of retrusion and the angle and amount of surtrusion which has to be accomplished to get from maximum intercuspation to centric relation. Here is a motion graphic which attempts to illustrate that composite movement. Notice that the condyle is sliding up the eminence, and it is also getting closer to the eminence as the disc retrudes to the central fovea. We'll run it again. So these are the components of jawbone geometry when one chooses to alter the occlusion in order to move the occlusal contacts from those in maximum intercuspation to whatever they must be to achieve centric relation. In summary, when altering the occlusion from MI to CR, the mandibular postural change versus the maxilla depends upon how much, if any, retrusion is required, how much, if any, surtrusion is required, and the angle of the eminence. Also, whether one recouples the anterior teeth or not alters the amount of tooth structure that must be removed. Part 3 of this series will discuss techniques for capturing centric relation and techniques of equilibration, whether one is dealing with an orthotic or the natural dentition.